up with how you were, and I was like, oh, I gotta talk to Karen. So see me,
Okay.
because I think I made a mistake possibly, and I just want to
Okay.
rectify it if I did.
Hey,
So, anyways, today we are going to. I want you to know that Farm 5, and I'm saying this for you, O'Neill, that Farm 5 was the hardest test.
Yes.
It was. It is very hard when you start hearing acetylcholine and anticholinergic, and to try to get those straight in your mind. It takes a couple rounds. At least it did for me, anyways. And you guys, I feel like I'm for the same age, I was at the same level as a class as you are. Okay, so it takes a little bit, and then unfortunately we jumped off of that, and then we went in just to a one-day lecture. I don't know about you, but my mouth was dry yesterday, afterwards. And so, but I just felt compelled to give you the information and just to kind of clarify a few things. With congestive heart failure, usually the heart in its entirety does not go kaput simultaneously. Okay, usually what happens is that on the right side, that it is having a hard time getting blood up to it, and it's having a hard time pushing on the right side. So as a result, you see edema, but then that blood is going to the lungs, and so you see edema on the right side. You might see it a little on the left side, depending if you were there right as it was beginning to drop out the bottom. You would only see it on the right side. But as time would go on, you would end up seeing edema on the left side. But let me explain the continuum, okay? So then it's not pushing hard. So initially you just see that right-sided edema. Then as it gets so much blood in it that it has to, no matter how poor the push is, it's still going to the lungs. But now it can't get out of the lungs, okay, because there's not enough oomph behind the contraction of the heart. So then you're going to hear the lungs are wet. So you can't think pneumonia or some other type of respiratory disease. What you have to think is this the start of heart failure? And then it comes out of the lungs and goes into the left side of the heart, and it's still, now if it was floppy on the right-hand side, eventually that workload is going to slow down the left side too. Because our bodies, I haven't said this, but our bodies are meant to bring us joy. Is that wild? Our bodies will overcome any obstacle, will compromise to the nth degree for us. And so, but at some point, that compromising, the bottom falls out. And when the bottom falls out, then that is where us as healthcare professionals, okay, with you guys, if you were to come to me, I'm not a nurse practitioner, I'm a clinical nurse specialist, but I am qualified to do advanced assessments, okay? With you guys, it's this big swing. If something goes wrong with you, 5 other systems jump in there and take over and just kind of keep it so that you can continue your activities of daily living. With the people that I'm talking about right now with congestive heart failure, instead of being able to swing with compromising on their body, this is how they are. You do a little here, and then it shows up over here. And so that's what I'm talking about right now when I'm going into left-sided heart failure. When you go into left-sided heart failure, now what is happening is what little umph the heart had on the right side, it's even less. It's now affecting the right side. It's not enough power to pull blood out of the lungs entirely, and it's not enough power to keep this thing circulating. And so then as a result, when you're in total heart failure, total congestive heart failure, that is when you see edema on both sides and in the lungs. Initially, when that happens, you just see a little bit of edema on the left side until that bottom drops out. Then you're going to see total edema, total wet lungs. So then it becomes our responsibility and say to the person, like first you're going to hear it. Okay, it's not going to be a lub-dub, lub-dub, lub-dub. It's going to be muffled. Why is it going to be muffled? Because whenever there's water, blood, or liquid over any sound in the body, it comes muffled to us through our stethoscope. So anyways, I wanted to clarify that. Then another thing that I wanted to clarify, and I was thinking about you because you were, okay, so steroids. I say steroids and you guys think? Immunosuppressant. You think? Blood sugar. Blood sugar? Blood sugar, yes. Blood sugar. I had anti-inflammatory on my mind. Okay, yes, that is true. Those three things. Okay, and then so our folks with asthma. Now, we take asthma fairly lightly because we all know 2 or 3 people with asthma, and we all see them take their inhaler, kind of sit for a minute, and then go off and participate. So we just think, oh, okay, no big deal. Well, I want you to know the hallmark of asthma are those 3 things that we stated yesterday, and they are excessive fluid, the lumen constricts, and then it spasms. So here it is normal, here it is constricted, and then it spasms, it kind of goes in. So those 3 things happening simultaneously, well, you can see very easily that if you get enough fluid, and they can't control the fluids, right? They're just being produced. Okay, it's really wild. Did you know that our bodies make 150 to 180 mils per day, our stomach does? Our large intestines, the main function, I mean, besides, contracting or, compacting the stool and forming the E. coli, to evacuate it, what the main thing that the large intestine does is that it reabsorbs 5 liters a day. Because I got it confused on 5 liters of blood, but it is 5 liters a day. That's a lot of fluid. So then when you have a patient with a colostomy, you need to be thinking, anything lowered, anything distal from that colostomy, they're not reabsorbing fluid. And then you've got to think, oh my gosh, that's one of the 3 that got drilled in my head in 084, pH, fluid, and electrolytes. So now it's your job to make sure that fluid gets on board. Okay, so going back to this. So that is kind of the large intestine, but now let's go back to asthma. Okay, that's where we started. So you're making, just by virtue of being healthy, your stomach, 150 to 180 mils a day of fluid in your stomach. Why? Because when it starts to agitate and turn, if it didn't have fluid in there, it would be too hard, right? There wouldn't be any you've got to make it into chyme, otherwise it's just going to paste out and become cement, right? The food. Okay, so then now add that with asthma. They're hyper secreting. And it's not just in their GI tract, it is in their lungs and in their airways. So asthma can become a very deadly, because we take it casually, because we, have pharmaceutical companies so willing, and rightfully I'm thankful for it, give us our little, inhalators or, inhalers. We don't think much of it, but asthma is deadly and can kill. So then you have to think, okay, so some of these inhalers, like Proventil, works right away. Why? Because if there is a spasm, a constriction, and all this hypersecretion, if you wait 15 minutes, the person's going to be dead. So you have to have fast-acting inhalers, and then we talked about some of the long-term inhalers just to make life a little easier on them, so that, hey, if I want to go play soccer or basketball, or I can, take a couple puffs, and in 15 minutes, 60 minutes, go out there and play, right? And not feel ostracized because I can't participate. So there's those two different inhalers. But then there's kind of this mid one that has both a steroid in it and a bronchodilator. Okay, so then I want to clarify it. The bronchodilator is opening up the airways so that the steroid, that's an anti-inflammatory, can go in deeper. Okay? So any other questions or thoughts? Those were two of mine from yesterday's lecture. Any other thoughts or anything on respiratory, cardiac? What else did we do? Yeah, I don't either. It was a lot. And I do want you to know that we're going to have a couple more pharmacology lectures, and then we're going to get into behavioral health. I'm going to, next week, the first day, Monday, behavioral health, I should say behavioral modification is 20% of your state boards. Okay, so I want to give you the information early enough so that you can start reading it. But it's very interesting. This is kind of why you're here, is because of behavioral health. And this behavioral modification is kind of beginning to pave the way. This pharmacology stuff, it's important. I don't want to underplay it, but it's not 20% of your state boards. Let me just put it that way. Okay? So anyways, anything before we get started? Okay, so we're going to talk about NG tubes today. Okay? This is a big deal. This is kind of like, what's that?
Nothing, sorry.
It's kind of like injections. You know, it's like, this is what the real professional people do. They place NG tubes, they catheterize people, they give injections. So this is, and they suction, and they do trach care. Okay, that's what we do. And so this is it is going into that. So we've already talked, get a piece of paper and pencil out, if you will. And then I am going to send this around. If you will please sign it. Today's date on it, it is, September 8th. Oh, that's weird. I gave it to you anyways, but thank you, I appreciate that. So, this NG tube, the purpose of it, and we've said this once before, but now we're saying it where you're going to be tested on it, okay? So I want you to have it in print. The three reasons why an NG tube, and NG stands for naso, nose, gastric, stoma means mouth, gastric means stomach, and pep, like Pepto-Bismol, pep means to digest. It usually refers to the first two areas of the small intestines, right? The duodenum really is the main, that 8 inches pretty much absorbs all of the food that we take in. And then a little bit in the duodenum, and then the jejunum, and then the ileum. Ileum actually means to rest. Because when they were back in the day of Angelo, when they were, robbing graves and cutting people up, like this was something like the Catholic Church was like, you don't desecrate the body. And these guys were out there hungry for science. And so in the middle of the night, they would go and rob graves, dig them up, and, start kind of chopping away, if you will, seeing what was going on. And every time they got to the ileum, there was never any movement. And there was nothing in it. So that's why they named it ileum, meaning, really empty is what ileum means. Okay, but anyways, so the three reasons why we're going to pass an NG tube. write down decompression, lavage, and feeding. So decompression is when someone has had abdominal surgery. If we don't put an NG tube down, that 150 to 180 mils that the stomach is making will pass through the intestine, and that is enough pressure to put up against the incision line to cause it to dehiss. So therefore, we have to put an NG tube down with anyone that has any type of abdominal surgery. And then we learned in our GI lecture, that is the most disease processes circulate around the GI tract.
What was the word you used? Cause it to?
Oh, dehiss.
Yes.
Yeah, that's the word I couldn't spell on the board at one point.
Oh, okay. You went over
Yeah,
it. Okay.
so you guys feel comfortable with the word dehiss. Dehiss means that it's going to pop open and the guts are going to come out.
I've seen that somewhere before. It may have been a test or boards or.
Okay, good, thank you.
Okay, just
Um,
making sure.
So like the acid from the stomach could dehiss
Yeah, it's kind of like back pressure from the stomach is putting pressure up against that incision, so much so that it's going to pop open. Okay?
So it has to be basically open for it to come out or
So we put an NG tube down to pull out the fluid so that that fluid doesn't go down the intestine and create back pressure on the incision. That's why we're doing it. And then, pardon?
for decompression.
For decompression, that is correct then.
Is that what they say, like in the hospital, they say they pump your stomach?
Oh, no, we're gonna get to that. That's the lavage part, when they pump the stomach. Good segue, thank you. Okay, so a lavage in French means to wash. And so when you lavage the stomach, what you're doing is you're washing it out. So when someone comes in and they OD'd, we have a couple options. Okay, so the first question we ask when they've OD'd is, what did they take? How much and how long? Because the full treatment plan is spun off of those three questions. What did they take? Okay, so let's say they take Tylenol. Yesterday we learned, and it still kind of blows my mind, that the antidote for Tylenol is mucolytic drugs. We learned that yesterday, right? That's weird. Don't you think that's weird? I do. So you're thinking antidote, you're thinking absorption. So how long did they do it? Okay, so if they did it 4 hours ago, then you know that the stomach is already beginning to absorb it. Yeah.
We had a test question yesterday. I forget what the exact name of it was, but it was like a medication that makes you throw up.
Okay, Epicat?
Yeah, and it gave like 4 examples, but it was like you weren't supposed to take it if you were unconscious, right? It was
Right.
Like, it was a
Right.
necessity.
Thank
and there
you.
was like OD on tranquilizer or something like
Okay.
that. And that's the answer I picked, but
Yeah.
the right answer was,
That's a good one. So what's the other one? Because that must be better.
yeah, it was something about like gasoline or petrol.
Oh, yeah.
And I was like, how does that make sense? Is it like
Yeah, I wanna go
patients that
back
you
and-
make, right?
And then there's one that's like bleach or something, or laundry detergent.
Yeah.
I think that one, because I'm like, it burned on the way down, in fact, that's how I was thinking.
Yeah, that's what I
I
was
remember you told me,
thinking.
like,
Yeah.
don't do that.
Yeah, if it burns down, you don't want to create a double burning. Gasoline's going to do the same thing.
Oh, damn.
Yeah,
So that's why from what you've said, I would have chosen tranquilizers.
yeah, I
Because
took the
there's,
tranquilizer.
you take a tranquilizer, right, there's no burning going down. So let me look at that, and then I'll give more information on that.
I think students had asked that in the past, and Marianne,
Right.
I listened to Marianne, she says that just like, have you ever seen? It goes down, it's gonna burn going down, then it mixes with stomach acids, right? And it becomes more corrosive. So then then you bringing it back up through your esophagus, you're gonna cause more damage to the esophagus because of the combination.
So that's just with
So
gasoline.
you don't, huh?
Well, it's with gasoline, bleach, acid, any, cleaning, a lot of cleaning chemicals have acid in them, right? Anything that's not pH balanced is usually more acidic as far as a cleaning product than it is alkaline. And so those you want to watch out. Let me find the question, read it, and then I'll explain it in context. Because from what you're saying, I would have chosen tranquilizers.
Yeah, that's what I thought, but it was like OD tranquilizer or something like that.
Okay.
So I don't know.
But, so getting back to this lavage thing, so you want to know which drug, you want to know how much they've taken, right? Because the more they took, the more toxic it is, the quicker you have to work, and you've got to maybe do 2 interventions simultaneously. So if you were going to choose not to go the antidote route because of the severity to the person, then what you're going to want to do is put down an NG tube, and you're going to take it into the stomach, and either you're going to dilute the stomach, or you're going to pull it out, or you're going to absorb the toxin by putting charcoal in. And charcoal is just like what the barbecue that you would put, the brochettes that you would put on a barbecue. It's that charcoal just ground up. And so then when it comes out of the NG tube, it makes a mess, but you're saving someone's life, so that's cool. So that's what lavage is, okay? That is typically done in like the emergency room. Yeah.
Can you repeat the 3 ways? It was the NG tube, the charcoal, and what else?
NG tube, you could, and an antidote.
Oh.
Yeah, you've got to get in there, and you've got to neutralize it. You've got to pull it out. You've got to stop it from absorbing, because once it absorbs, then the toxicity will go up, right? And it's going to do damage to the person. And, okay, now Epicat, if you caught someone just ODing, right there, and you saw the pills and you saw what it was, and you kind of knew how many was in there, not to the, to the number, but you could tell that they took 1/4 of it or 1/2 of it, the bottle. Well, then you might go, and it wasn't corrosive, you might do Epicat, because then that's just going to take what's there in the stomach, and it hasn't broken down, and it hasn't absorbed, so you can then pull it back up. But when you do Epicat, you have to make sure that the person is, in their right mind, because as they throw up, you don't want them to aspirate it. Now you have 2 problems, okay, where you just started with 1. Okay, so that is in the environment of the emergency room, where minutes really count. Thank you, Benny, I appreciate that. Where minutes really count. Then, where we're going to be seeing it a lot is with feeding, okay? A lot of our patients, their mouth is, the mandible, they can't handle food, they can't swallow it. They don't have control over their tongue. Their teeth are misplaced. They have a problem with saliva where they can't swallow it. And so therefore that gets in the way of them eating. Sometimes people come out of surgery and they might have a feeding tube put in. But then when we do this, Kate, I want to go over. So what it is it's meant to put food down it. It's a commercialized food that is liquefied, and different brands, have different ingredients within it, okay, that would be appropriate for the patient, whether, they need high protein, right, after something has happened to your body. Okay, young kids use protein to grow on. We use protein to replenish, okay, because we're constantly things are dying within us, cells and that type of, at a microscopic level, and we have to, repair that. We have to have meiosis, mitosis, whatever it is, and we've got to then, and protein is the basis of that. And incidentally, that is why you need B12 in your system, is because without B12, you don't have replication of your cells. Okay, why am I bringing that up? Because peptic ulcers, which we think of as like no big deal because we go to the medicine cabinet and grab antacids, well, when we do that, we are extinguishing the parietal cells that make not only HCl, hydrochloric acid, but they make intrinsic factor, and that intrinsic factor is needed in order for your cell to absorb B12. So when we talk about that here in America, most of us, and I'm trying to get you not to do it, and I really try, honestly, that's why I take aspirin maybe 3 times a year. I haven't taken an antacid probably in 5-6 years. I honestly don't remember. You want to teach your patients to stop the precursor that brought it on. Because why? We're about anticipating and preventing. Okay, so when we lead that lifestyle, it's easier for us to teach our patients, right? Okay, but anyway, so back to this feeding. So there's different products on the market, and they have different levels of carbohydrates and protein depending on what the patient needs. So it's prescribed by the physician which one is going to be used. Sometimes they'll defer it to the dietitian. And then the dietitian will go in, look at the labs, and see what needs to be placed in that feeding. Okay, so then the order's been written, and it's not going to say, the order is not going to say start NG2. The order is going to say place on liquid diet of, I can't think of a brand name right now.
Sure.
Yeah, Ensure we drink typically,
Yeah.
but
Sometimes they order that in.
okay, Ensure 250 mils in 4 hours, followed by a liter of fluids or dilute with fluid. They'll have some type of order there. The ingredients for the order comes up from pharmacy. But just because now that they have ordered that feeding and it can only go in by way of a tube, then that's when we place it. Okay, so we've talked about 2 words in this class that I want to clarify and tighten up. We've talked about a gauge of a needle. Now we're going to talk about French. Okay, so a gauge of a needle is the width of internally of the lumen. Okay, that's the gauge. And we said that the larger the number, the smaller the gauge, right? Now we're going to introduce the word French, and it is French, French. And that is the circumference of something. These feeding tubes, these NG tubes, are measured in French. So usually, and the higher the number, the bigger the circumference, the outer circumference is. So we have to know that, right? Because, an adult esophagus is going to be able to handle a larger French than someone smaller. And then French sizes are also used with Foley catheters. Okay, and we're going to get to that next week. Okay, so now I want to, so that's kind of the theory behind it. That's the purpose behind why we're going to pass these NG tubes. Now I want to talk pragmatically on how we're going to do that. Okay? Unfortunately, for an NG placement, you don't go to the clean utility room and grab a box. Okay, the way that you do with a lot of other things. It's individual type things that you have to grab. So I want to go over the equipment. before I get to the equipment though, you're gonna be starting the process. And what you need to do is to take a pin light, you can take a flashlight, you're gonna have the person tilt up, and you're gonna look into their nares, okay? Because one nair is usually bigger than the other nair. Okay, so you wanna find which nair, and also which nair is more direct. So if someone, I remember I was floating in the emergency room, and two little boys were playing golf, and one little boy was standing there as one little boy went up with the club and literally took his nose off to the side. This little kid came in like literally with his nose over here, about 5, 7 years old, screaming. Oh, you just feel, when someone's in pain, and it's legitimate pain, you just, oh my gosh. But anyways, so you can have what they call a deviated septum, where someone has taken a blow to the nose, fist or golf club, and when they go to put the nose back, it's never going, as is with any surgery, as is with any mishap, it's never, the body will repair itself, but it's never the full integrity it once was. So you need to look and see which nair is larger, and then the concha, those little shells that are in our nose that keep the wind whirling to provide humidification and to, so we can take in cold air and hot air within one day or, within a time period. And the concha is what turbinates the air to bring it to a temperature that our body can handle. And so the concha are up in there. And so you want to look and see which nair is most direct, where the septum is, and you want to kind of look and see if you can get a path up there. Then you are going to take, and this is where I want to write down all of the equipment. You want to take an NG tube, and it's going to come prepackaged with just the tube. By you assessing that nair, you're going to look at what kind of French they can handle. Okay, what kind of circumference of the tube. So you're going to note the French of it. Okay. You're going to need some lubricant. I'm going to put KY jelly. Okay, now remember that when you put a petroleum-based jelly on a person and they have oxygen, you can cause their face to ignite, especially if they have a mustache. Yeah, this is important, and that's why we're talking about Okay, oxygen is everywhere in the settings that we work, right? If it's not coming through the walls, we have E-cylinders and, different size cylinders that are hanging around. So, when you get like petroleum jelly, that's made from oil. Oil is combustible. Things burn faster and quicker with oxygen. So you cannot use, it has to be a water-based gel that you use. And you have to be aware of that. Oh, bless your heart. You have to be aware of that when you are working in a hospital. Why? Because you might have patients that put on chapstick. Well, chapstick is petroleum based. And if they're also on oxygen, you can't mix the two. Okay, so you have to, that's why I'm specifying KY jelly. And we are going to put a little bit on the tip of that NG tube. Okay, let me back up a second here. You will either have a portable suction machine or you will have a suction that is in the room at the head of the bed. These suction machines have different millimeters mercury of pressure. So it's millimeters mercury of pressure. And with this, if you put that machine up too high, you will literally suck the mucosa out of the patient. Okay, so with this is usually at 80 to 120. I know I'm speaking fragmentedly. I'm going to pull it together in just a moment here, okay? It needs to be 80 to 120. So on our littler folks, we need it more towards 80. And on our larger folks, we can have it. But what we're looking for is the least amount where it is either, in this case, pulling things out of the stomach. Okay? Here, when we start talking about what is going in, we're talking about decompression and lavage. When I say going in, the pressure going into the patient. When we're talking about feeding, we're going to be talking about a feeding machine. Okay? And then we're going to have pressure on that machine to get the food in. Okay? This is what I wanted to say though, so I'm backing up a little bit. Not only on this piece of equipment, on this suction piece of equipment, is it going to say how much pressure you're going to deliver, how much suctioning power. Now remember, the stomach, if you pressurize the stomach and don't equalize that pressure, you will collapse the stomach. So these feeding tubes are not just a tube. There are two tubes in there. One that is open to atmospheric pressure, and then one that is either putting contents in, such as feeding, or pulling things out, like lavage or decompression. You have to have that second tube within that tube, because if you don't equalize the pressure that you're putting in, it will collapse the stomach. Okay? So then, a spin off of that, the machine will say, do you want to have intermittent pressure or do you want to have continuous pressure? Intermittent pressure is that it's going to turn on, go up to what you've set it to, 180 to 120, or excuse me, 80 to 120, and then it's going to shut off. Why is it doing that? It is doing that because, let's say this is the stomach, and the tube is in here. And this tube has little openings in it, so it can either drop the food in or pull out the drug. Okay? When it hits the pressure, this tube will kind of sway because it's jolted by the pressure behind it. And that sometimes will hit up right here. And then it is intermittent pressure, so then it will release, it will swing back to the middle. Maybe it will hit here next time and here. Maybe it will stay within the middle. But that intermittent pressure is meant so that you don't suck off the mucosa and erode it in only one spot. Do you see? If it were continuous and got up on the mucosa, it would just like literally start to degrade that fine, moist mucosa. So you've got to have it intermittent when you are decompressing, so that it doesn't just hit one spot. Then the other cycling on that is continuous. Continuous is, man, you want to get in there and you want that drug out. The person came in, they had taken half of a bottle, at least. They took it 3 hours ago, and you know that before it starts to fully absorb, you've got to get in there and pull it out. Well, then you're going to use continuous, because you're going to want to empty that stomach as quickly as you can. Okay, so we talked about pressure, and we talked about intermittent or continuous suctioning. Okay? So let's get back to our equipment here. Any questions on any of this so far? Yeah,
So the
Leslie?
pressure is measured by millimeters of mercury?
Yes, it is.
Is that how you say it, millimeters?
Yes, that's exactly how you say it. As is a stethoscope is measured that way. Okay? Did you have a question, Benny?
Yeah, so like, what would feed be used for?
What would what be?
Feeding be used for?
Oh, feeding tubes? Okay, let's talk about that. Feeding tubes are used for us to give us protein so we can repair. More than likely, we're going to, if we were to have surgery and we couldn't eat because we had surgery of the stomach and they cut into us, like a colostomy, right? Well, afterwards, we can't eat, but we still need to repair. So they would put a feeding tube in us so that we could eat. That's not totally true. They would give us an IV in that situation so we could eat, and then a feeding tube would be for decompression. Okay? But then after we're on amends, and because to feed someone IV, literally a liter of that food, and I'm not exaggerating, is $2,000-$3,000. We just recently had a friend who had surgery. He has cancer of the prostate, and Wayne kept bugging him, get in there, get in there, get in there, because I was always bugging Wayne. You need to have your prostate checked. I don't care. I know it's weird. I wouldn't want someone to put a finger up me either, but guess what? You know, it sure beats the alternative. And so at work with a bunch of guys, you know, they're harassing Wayne. They also harassed him when we got our poodle. But anyways, you know, so he takes a lot of heat for different things. And Wayne was, you know, defending it, saying, hey, listen, you guys, prostate cancer is real. Once it goes to the bone, it's a kiss of death. You know, and it's all preventable. Well, lo and behold, one of those guys, and bless his heart, I love him to death, that used to tease my husband, and this guy's a teaser. He just gets in there and he doesn't know when to stop. He's teased me a couple times, and I'm like, holy moly, you know, I want to leave this guy. But anyways, he got cancer of the prostate. Had to have surgery. Now he's going for radiation because the surgery didn't get it all. Okay, so when you have surgery and you're on the amends, you will have a feeding tube at that point. Okay? Yeah.
So my grandmother had aspiration pneumonia, and she's on the peg tube now. Would that be?
Okay, very good. That's it. Okay, we'll talk about that in just a second. Did I answer your question?
No, I meant like what type of pressure you use for feeding?
Oh, for feeding? Okay. For feeding, there is no pressure to use. The pressure comes from the feeding pump to put the feeding into the stomach. Okay? And that's standardized. We don't worry about it on that. Okay, so now we're talking about NG tubes, right? And now there's another thing called G tubes, gastric tubes. That is where the tube, or a peg tube, sometimes they'll call it, that is where they're going to place a tube right into the stomach. They'll put a hole in the stomach. They'll put the tube in. Actually, it's weird if you've ever seen it. They take the tube down the mouth, and then through ultrasound, they make sure they're up against the edge of the stomach, the lining of the stomach, and then they incision and pull it out through the stomach. And there's this little cup on there that keeps it in. And then this gets hooked up to the feeding. Okay, now that's a gastric tube. An NG tube, and thank you very, very much for bringing that up, because an NG tube is a short-term solution, okay, where we're expecting them to heal and everything's going to be on the amends. When it's a long-term, then they're going to have, remember I said gas means stomach? They're going to have a gastric tube put in, or sometimes it's called a peg tube, okay? So that's for long term. We're gonna be feeding them for years that way, okay? Were you gonna say something,
I
Karen?
have a question. So when I was watching the video last night, when a patient comes to our facility, they would already have that incision and the main tube in, right?
Yes.
And we would just stick the other one for feeding. Like, we'll never put the main one in.
No,
Okay.
that's a surgical procedure done in surgery, okay? Because they're cutting through the stomach and then all the layers of the skin, right?
Body, okay.
Yeah, Veronica?
Okay, so that's the G2 that comes out through the side of the stomach. So what about, is that the same one that reaches the small intestine?
Okay, very good, very good.
Because I wanted to know what's the difference, like that one reaches the small
Yeah.
intestine instead of staying in the stomach.
Okay. Remember I made such a big deal about the contents of the food being delivered? Okay, part of that big deal is this tube, then we have the duodenum that comes around, right? And then the jejunum, and then the ileum, and then it curves and, starts, well, it goes into the large intestine. Sometimes they'll put that tube right in the stomach. Other times they'll take it through the pyloric sphincter and put it in the duodenum. Food that goes into the duodenum is more sophisticated and has to be more thought through, more broken down, thank you, when it goes into the duodenum. Okay? And so it depends on what happens if they have cancer of the stomach. Well, we can't put food in there, if we're having surgery and radiation on the stomach. We have to have it go further down.
So you bypass the stomach basically.
Yeah, absolutely. Okay, so, thank you. That was really a cool conversation, you guys. Okay, now let's get back to the equipment. Okay, can you tell I'm really trying to stay focused? Because this conversation gets very voluminous, and I want you to feel secure with it, so I'm really trying my best. Okay, so we want to have KY jelly here, okay? What we're going to do, we've already looked at the Nair, we already have the NG2, and then we're going to take the tip of that NG tube and kind of put it in the jelly to kind of get it slick a little bit. We are then going to have the person, okay, now if the person can help you, you want to incorporate and tell them what you're doing, and you would explain this. Your doctor ordered feeding for you. As you know, you've had stomach surgery or whatever is going on, and your doctor, you still have to eat. So we're going to take a tube, we're going to take it through your nose and down your throat into your stomach so you can eat. So you want to get their help with it. Because an NG tube is probably the most miserable thing that you're going to do to your patient. It is easier for a patient to accept getting a Foley catheter than it is an NG. It is amazing to me, even the last time I did it, the patient looks spry and chipper and everything, and then you put that NG tube, they go into the sick mode like, because it's miserable to place, it's miserable to have when you move. When you move with a Foley, yeah, you can feel it down in your groin, hit your thighs and that type of thing. But up here, you're constantly moving your head. You're not, when you're laying in bed, moving your hips so much. Do you see what I'm saying? And so it's very irritating for people. Yeah, Veronica?
And I have a lot of questions.
That's okay.
So what about when you have the tube, I'm pretty sure you could feel in the back of your throat.
And you
when you're,
can.
you have your saliva, and you just, put your back, does it bother you?
Yes. It's irritating to them. It puts them in the sick mode, like no other. And you're going to notice that. And you caused it. So you feel kind of weird. And if you're not a little kind of have your armor on, it's easy to give in to them and say, okay, yeah, let's do this later. Because I'm going to tell you that you You might think it's a trick, but it's not, and I'm coming up to it. Okay? Anything else? Okay. So then what you're going to do is you are going to have them tilt their head back. You're going to go into the nair that was the one that you chose. You're going to go back a little bit. You're going to feel the back of their throat where it starts to curve. So you're going to go in through their nair. And incidentally, you can go in through their mouth, but typically we don't. You're going to go in through their nose, and when you get back here, you're going to feel the tip of that NG tube hit that area. That is where you say to the person, take your chin and put it to your chest, and then you have a cup of water. You have a flex straw. Oh, Vanna, hi. You thought her name was Maria. It's Vanna White.
Swallowing helps it go down.
Yeah, and then you're going to say to your patient, they're going to hold it, and you're going to say, swallow, swallow. Because with them swallowing, you have peristalsis. Did you know that in your esophagus? So, but by them swallowing, it's causing the peristalsis to, with that negative pressure, to pull it down. And then at the same time, you're going to be pushing it down. And you don't want to do, these little boom, boom, boom. You want to And this is, you're going to say to the patient, if at any time this is difficult on you, put your hand up and I will stop. Okay? Because this is so taxing on them, when they put their hand up, put one more good sweep in. Because if you don't, you're not going to get it in. Because once it gets back there, they don't want it. And they're going to deny it, but then how do they eat? Okay? So you've got to be a little bit, tough mentally and be able to look at their discomfort and go beyond it, knowing that you're doing good for them. Okay? So then they're going to put their chin down, they're going to be swallowing, and it will get around this area. Okay, you want to make sure that it doesn't go into the lungs, is the next mishap that could happen. So if they start, and you don't hear anything, you know you're in the lungs. So then you're going to pull back a little bit, but not entirely. Because if you pull that thing out and they see it out, they're not going to want it. So you're going to pull back a little bit until you hear,
It's like the gag reflex.
Well, it's beyond the gag reflex, okay? The gag reflex is in front of the uvula, back at the throat. This is, we've passed the uvula. The uvula is like right about here. We're, down past, and we went through into their epiglottis, and now we're going into their lungs. So you're just going to, and, if you don't respond, they're going to turn blue. So you're going to pull back a little bit, kind of twirl the NG to get it to go down into the stomach. Yeah, not often. I've maybe passed, I don't know, 150 NG tubes. It's happened to me probably about 15, 20 times. When they start, and you're like, okay, and then you pull up a little bit, not entirely. And then you twirl it, and you're trying to get it so that it comes down here. Okay? So then, now you have it in their stomach. Okay, now let's talk about the two tubes that are within it. Yeah. Yeah, absolutely. What time is it? Just a second, because you have to have this information before you go. It is 7:26. Let's come back at 7:35. Okay, a 9-minute break.
I could not find NG2.
Oh, okay.
There is no NG2
Oh,
in here.
right here.
Oh. What is this one, Kim?
I went to the concert yesterday, and they said they're already literally in like they don't do long.
Okay, let's get in so we can get going. Okay, one thing that I want to share is before you put the NG tube in, what you are going to do, because you need to know how far to go with it, right? It is from the tip of the nose. You're going to take this NG. Here is the NG tube. I want to explain a couple things on this. I want to explain this sump, which is the equalizer, so you don't decompress the stomach. But you're going to take this. Here, do you see the holes in it right there? You're going to take the tip. You're going to go from the tip of your nose to the bottom of your ear, the lobe, and then you are going to take it and you are going to go to the bottom of your sternum. Okay, so you have the manubrium of your sternum, and then the tip is called the xiphoid. So the manubrium, the body of the sternum, and that little gatch down at the bottom, it's not on there, is called the xiphoid. Xiphoid, P-H-O-I-D. I think it's X-Y. X-Y, P-H, xiphoid, O-I-D. Xiphoid, is that right?
That's right.
Thank you. So, you're going to go from the tip of your nose over to the ear and then down to your xiphoid. Okay. That is where then you will need to have either a Sharpie. Some people will put and mark it with a Sharpie, or they will use tape. And put a little piece of tape there so that as you have put the KY jelly on, that when you go down, they get to this, you're going to tell them, take your chin to your chest, take this water and swallow. When they do that, then you are going to see, look at how hard it is when you don't have that. You can do what I'm doing, which is, but the positioning, the anatomical positioning. Okay, this does not want to go down. It's too rigid. Okay, there it goes. Okay, so here it's there, and then you're going to take it. Okay, it doesn't want to do it. Okay, but anyways, you're going to take it to where you put the tape or the Sharpie. You're going to bring it up to the nair, right there. I've got two thoughts going right now. I'll come back. But what I want to explain is that this right here, this blue thing, is running through this. And you can see that it's a tube within this tube, that it's running down? This sump, it's called a S-U-M-P, sump. Has to stay upright. So you'll tape it onto the patient gown. You want it upright. If you have it down, it will get fluid in it that it's draining, and it will drain over the patient. So it has to stay upright. Okay, so we talked about the measuring of it, right, just now, how to measure the length. And then once it is in, then you are going, this is very heavy, and remember we talked about decubitus. This will irritate the nair and cause a decubitus at the nair. So what you want to do is you want to take your tape, here's the Sharpie. I do not have any tape here, so listen up. You want to take the tape. Let's pretend like this is in my nose right here, okay, in my mirror. You're going to take the tape and you are going to put it around and you're going to create a chevron. So you're going to put it under, you're going to put it over the nose. It's going to bifurcate and have two, you're going to take the tape, have a little piece of tape, and you're going to split it up. You're going to take the side that's not split, you're going to put it over the bridge of the nose. Before you do that, you want to take some alcohol and you want, because have you noticed you perspire a lot through your nose? The younger you are, the more you perspire through your nose, and you get blackheads and whiteheads on your nose. Then at some point, in your mid-20s, that kind of stops. Well, you still perspire through your nose. So you want to take the alcohol and wipe their nose and put a little, action behind it and let it air dry so that when you put the tape on it, it is adhering to the skin and not the oil of the nose. So then you're going to take this tape, you're going to lay the piece that you didn't split over the nose, and then the pieces that you did split, you're going to take one from this side, wrap it around, and then twist it along here. This side, on this side, you are going to go over and wrap it around. That will make more sense when you get in lab and actually do it. But it's called a chevron, just like the gas station. And that is how you are making the tape. Okay? You're making a chevron with the tape. Piece of tape goes over their nose. You have split the tape up. One piece is going to go under this tube and then wrap around it, and the other one's going to go over it and wrap around. Then you're going to take a piece of tape and go over the nose tape just to add security to it. Okay? Then this is still heavy and it can still ulcerate the nair. So what you're going to do once this is in, you are going to put a little kink in this. It's actually going to go, this is not the NG tube, this is the extension. This will be up my nose, down my esophagus, into my stomach. I am going to run the tape over it, put another piece of tape over that chevron tape, okay, on my nose. Then I am this right here. Okay, I don't have the right equipment here. Okay, so this is how it's going to be. So then I need the NG tube, and then I'm going to just call it an extender. But what I'm trying to say right now is that once this is in and taped, it's heavy. And so you're going to want to kink this, not kink it, but kind of create so that the weight isn't hanging all from my nose.
Slack,
What's that?
very slack.
Slack, thank you. Perfect word, Jason. Yeah, some slack. Take up. Oh, gosh, how to destroy a moment. I hope you know I'm sincere. Thank you. Oh, gosh. You're going to create some slack on this, put a piece of tape around it, and then you're going to take a safety pin. And you are going to put the tape around this tube and have a little tail on it. You're going to then put it by their gown and put the safety pin through the tape and through their gown so that you have slack in it. Okay, did that make sense? Okay. Then you have to make sure that the sump is upright. And sometimes they'll tape that to the gown too. Okay, now, as we said, this is a tube that goes right down their throat. You have to give mouth care every 12 hours minimally to your patient, because this is a source of bacteria that takes them. Not so bad going to the stomach because the hydrochloric acid will eat some of the bacteria, but obviously they're in a compromised state and we don't want to add more insult. So we're going to be diligent about brushing their teeth. Okay? And usually that's a pipette that we will take and clean their teeth twice a day, every 12 hours. And you chart that. And the reason why you chart that is because you're telling your reader, hey, I know how to care for an NG tube.
So if they can do it by themselves, do we still chart it?
Yes.
Okay.
And you just say, patient, administer, brush teeth independently. Okay. A couple things now that I want to back up on. Okay, write this down. This is probably one of the most important things about an NG tube. NG tubes for feeding must be, what's the word I want, Jacob? Must be sanctioned, must be done prior to feeding. Validate. NG tubes must be validated for placement prior to feeding. Okay, now let me tell you why. NG tube must be validated via chest x-ray prior to feeding. Sorry, Theo, for changing my verbiage. Yeah. NG tube must be validated via CXR, chest x-ray, prior to feeding.
You mean like okay?
Yeah, okay. Why? Because it has been recorded that this tube can get coiled up in the back of the throat, and people think it's in the stomach when it's not. They go to give the feeding and it goes down the bronchus and causes aspiration pneumonia. Okay? So you cannot start the feeding. That's the big, until you have that chest x-ray. Yeah.
In the video where it said testicles in the stomach, you would have negative pressure and to the temperature pH.
Okay. Let's go over that. Thank you. That's a perfect segue again. You can test this by way, as Jacob said, by pH. Why? Because the pH in the stomach is very acidic. So you could pull out, incidentally, here is a lure lock syringe. Do you see that? The screwing there?
Yeah.
And so you can have a Luer lock syringe that we talked about. This is a bulb, but pretend this was a syringe. This would be a tipped syringe. You see the difference there? Okay, so you're going to have a tipped syringe, and you are going to, and at this point, because you haven't started feeding, so that wouldn't be in, I'll pick that up in just a second. This is in. You are going to take this, put it, this would be a syringe, not a bulb. You're going to put it in, and you're going to pull back and get some fluid out of the stomach, some hydrochloric acid out of the stomach. That's going to be a super low pH.
So when you're pulling back, you're aspirating.
Very
right?
good. You are aspirating when you pull back. Thank you. And then you're going to take this content, put it on the pH paper, and then read it up against the bottle, and it's going to say that it's very acidic. Well, you know that that acidity only comes from the stomach. So it's safe to say that this is in the stomach. But you still, before feeding, have to get a chest x-ray. Okay, now let me explain to you, we have been in this dilemma for about 10 years, because that's what I used to do. And then I'm going to explain another test, the whoosh test. I'm going to explain that to you. But, okay, you have to know a little bit of this history to appreciate what I'm about to say. The lab, because it is such an area of diagnosing people, right? Most diagnoses either come from imaging and or lab, and mainly from lab. Because, and you have to have the right diagnosis to get the right treatment plan to cure the person, right? So the lab is this place that is heavily monitored and heavily regulated, because they realize that that's the crux of having everything else be successful for that patient. So they have this organization. We all know about JACO. JACO is Joint Commission for Accreditation of Hospital Organizations. That's what that stands for. A hospital has to be JACO certified in order to receive funding from the government. We've already said that 60% of all revenue comes from the government. You don't get it unless you're JACO certified. You also don't get it unless your lab is CLIA. Clinical Laboratory Institute Association, I think is what CLIA stands for. CLIA comes in every year to a lab. JACO comes in maybe every 2 years into a hospital. JACO is not specialized enough to go into the lab. Only CLIA is. CLIA has stated that you can only have pH paper in the lab. You cannot have it on the floors. So that pH paper test is then kind of taken away from us. So then they said, well, that's okay. We'll do the swish test. And this is a Luer lock. I wish, and Luer is L-U-E-R, Luer lock syringe. Okay, I wish this was a tipped syringe, because what we do, but listen to this, you have to have that chest x-ray before you start feeding, and it has to state that the tip of the NG tube is in the stomach, right? So these tests really don't matter. They're just kind of things that we do to make sure, but we can't start the feeding until we have that chest x-ray. And that will be a state board question, because that is entry level to protect patients. Because you don't want to feed their lungs, okay? At least not directly, maybe through the bloodstream, but not, you know. So then what we do is we take a tipped syringe, which I realize this is not. This would be in my nose, you know, down my stomach. okay, internally. I have this side. I take about, and usually they'll say, 15 to 30 mLs of air, and I'm going to put this in, put my stethoscope on, and place it, okay, now you guys know midline is the esophagus, and that the stomach is midline but to the left, right? And so you're going to take your stethoscope down and over a little bit and place it there. Have one of your colleagues push the air in, and you're going to say whether you heard it or not. It's called the swish. SW, how do you spell swish? ICH? ISH? Swish, thank you. SWISH. The swish test. This has to be performed by 2 licensed people. Okay, that's how important it is. But even as 2 licensed people saying that they heard it, it has been documented in literature that it was coiled in the throat and they just heard the air rush down, thinking it was in the stomach. So this pH test, which is valid, was taken away from us by CLIA. And the swish test is not 100% fail-proof. Okay, so that is why you need the chest x-ray. Okay, now this begs a question. So it started in there, how do I know the patient didn't move or pull it out a little bit? Well, because every time there is a chest x-ray, the radiologist has to state that where the placement of an NG tube is, if there is one. Okay, they have to. So you'll read the report, and the bottom paragraph of the report, it will say impression, and it will give you his impression. No infiltrates noted, or right lower lobe with infiltrates, NG tube placement in stomach. They always have to, whenever, or if they take a flat plate, chest x-rays and flat chest x-rays on hospitalized patients are almost, ordered daily, if not every other day. Flat plates, not as frequently, but they're still ordered frequently enough. So you have to check those, and you chart that you check those. Chest x-ray, impression states NG tube in stomach. Okay, so then this is in. The patient has had a chest x-ray. We know that it's in the stomach. We know that everything is good. Then we're going to go to the kitchen because that is where dietary will place the tube feeding. And we will hook up the tube feeding. Instead of this going to suction, it will go to it looks like an IV pump. They call it a tube feeding pump. And it will hang like an IV hangs, but it's the food. It will go through the machine and then get hooked up to this, and then the person will then start receiving their tube feeding. Okay? Does everyone, okay, now this was conceptual. We're going to go to lab. Okay, now let's go back a second here. In the order, it may state that you need to irrigate and or aspirate. When you are giving this person food, you don't know if the food is passing through. Okay, there might be an obstruction there. There might be a tumor there. The person may not have the peristalsis to take it forward. So the order will say, check feed tubing every 4 hours. If greater than 100 mLs, proceed. If over 100 mLs, wait 2 hours, check again, and proceed. So then, after, you will have it going for 4 hours. Meanwhile, you're palpating the stomach and you'll notice it being hard if it's not following through. So then you will take the tipped syringe. This is not a tipped syringe, but you will stop the tube feeding. You will take this, you will put it in. It's not going to stay in because it's a Luer lock. And you are going to, and this is a 60 ml syringe. My example said 100. So you would take this at 60. It's going to have feeding possibly in there. It may not. It may only have feeding up to 30, and you continue pulling back and no feeding comes out. Well, then you know that's less than 100. The order stated if greater than 100, stop the tube feeding. Why? We don't want to be putting food onto something that's not moving forward. Because if we do, that food will sit in the gut, and just like in your refrigerator, how it gets hairy and moldy, it does the same thing in our gut. And then it gets gangrenous, and you have to go in and cut the dead material out. We don't want that to happen, right? So that's why the doctor is having us check this. Okay, in this example, we got 30 mLs of feeding. And it came out, I can see the color is the same as what's going in. And then I pull back and nothing more is coming. In fact, it's harder to pull because nothing more is coming. I am going to push this back in, start the tube feeding, resume it, and then I followed out that order. And I'm going to chart that I did that. Okay, now let's say that I pull it back, it's coming, it's coming, it's coming, it's coming. Oh my gosh, I'm at 60. Okay, I'm going to take this out, have a clean cup. Oh, there's the tape. I'm going to show you a chevron. I'm going to push this in here. Okay, that was 60. I put it back in. I'm pulling it, I'm pulling it, I'm pulling it, I'm pulling it, I'm pulling it. Oh, I get another. I'm going to just, in this example, so we save time, I got 50. So that's 110, right? 60 and 50. That was more than 100. So I'm going to stop the tube feeding. I'm going to put this back in. I am going to suck this out and put it back in, the full 60. Stop the feeding. Wait, chart, note the time, come back. If it said resume, recheck in 2 hours. Then I will come back and do the same in 2 hours. Let's say in 2 hours I still got 110. That is when I get on the phone to call the doctor. There's a problem, Houston. Contact was not made. And that's what, Aaron.
What if we say it's like 80 instead of 110? Do you still call the doctor again?
If it's 80? No. Okay, the second time?
Yeah.
Okay, good question. So it's 80 the second time. That's less than 100. I push it back in and resume the feeding. But boy, in my mind, I'm like, I better check this. Instead of 4 hours, this is what I would do. Okay, so nursing, medicine, our field is part what? It's part science and it's part art. It's part aesthetics too. So I know that and it's well documented in literature, that what I just said is accurate. So I know, like how I said to you with the apical pulse and digoxin, if it's at 61, 62, I'm still nervous. I write 60. Because I'm sending the message to my reader, I'm obeying the order by not giving it. I do the same thing here, okay? With time, so instead of it being 100, it was 80, I pushed it back in, and the order said every 4 hours, I'm going to check it like maybe in 3 hours, 3.5 hours. Why? because I know if I put food onto something that's not moving, I'm causing more damage to the patient than good. And I am being super vigilant. When you say to your colleague, I'm monitoring that patient, I'm monitoring the NG output, what you're really saying to them is, I'm nervous, I don't feel good about this, I don't know if it's going to go north or if it's going to go south. South meaning that it fails. And boy, I want to catch it. The same thing, vital signs, when there's a catastrophe in the OR or in recovery room, they say monitor vital signs every 15 minutes. I know they fluctuate, but I'm on them every 5, every 7 minutes. Why? Because if they start to show a trending down, I want to be on it. Because you feel so insecure on the inside because you don't know how it's going, that's your only grip to knowing. Yeah.
So, referring to the tubes, when, just like the PEG tube, for the NG tubes, if it gets clogged, are you able to put the water and then stop priming it, go back to PM? I know it builds up.
Thank you, Denise. Okay, so what we're doing right here is, I had to look at you, Leslie, to make sure I was saying the right name. Because after that flub up, I'm very conscientious right now. Oh, I do have to say, it makes me feel a little good when a couple of you will say, I don't know his name. And I'm like, well, I do. Ha, ha, ha. Okay, so what you're doing is, yes, things can get clogged. And it is sloppy nursing when an NG tube gets clogged. We own NG tubes. We own skin, too. Okay, we own administering meds, we own. So if this gets clogged, it is sloppy care. We don't do sloppy care, especially if you graduate from here. Okay, because what happens when you do sloppy care, this is what happens. The graybacks, we're graybacks, the older people will go, oh, Martha, what school did you go to? I go to my nurse manager, my psych tech manager, and I say, the last couple of students we've gotten from there have been really crappy. And then they stop hiring you guys. Okay? Now, we want you hired. We want you paying taxes because I want to retire. I'm just joking. No, I want you paying taxes. Why? Because we get to enjoy this great nation of ours. And I really mean that sincerely. And I got to tell you, last night when I went to take those pictures, we went out to our balcony and I could see through the trees that there was a big fire over there. And so then Wayne said, get dressed, put your shoes on, we're going to walk down there. And I said, okay, yeah, I want to see that. I felt proud. I felt so proud when those firemen, there were about 10 units, and I mean big units. And my street used to be dirt up until about 15 years ago. And then they put tar over it, okay? It's not an official street. We still have horses and cows, well, not cows so much, but horses and ducks and everything in donkeys in my neighborhood, okay? Well, anyways, make a long story short, I was like, yay, thank you. Oh my gosh, is that wild? That rain is divine. That is a divine rain as far as I'm concerned. But anyways, where I'm going with it is I felt proud that my taxes went to having that fire department in that big, long, I'm not kidding when I say 10, there was 10, 12 of them going down my little street, going up to the fire. But anyways, and you too will feel that, and it's a good feeling, that you're contributing. But anyways, back to this. So, then what you need to do, see I got distracted, I had to look, and that came in, okay. So what you're going to do is you cannot get this clogged, but that tube feeding is thick, and it may be going at 60 mLs an hour, which isn't really very much. I like to see things like at 120. I like to, know that it's moving, okay? But anyways, so then this could get clogged. So you will have to read the order, and it will say irrigate every 4 hours with 60 mils. I remember one time I was at a hospital and there was a big earthquake, the Northridge in 75. I was working that night. And of course, all the patients wigged out. And I remember thinking, okay, here we are all together. Okay, but anyway, so what you're going to do is you're going, and you take tap water. Okay, now listen, this is going to be a question. They're going to ask you on your state boards, do you use tap water or sodium chloride? The answer is sodium chloride. When you are irrigating, you should use sodium chloride. That's wild, isn't it? Now the lights will dim off and it will be spooky. No, not really. So it is sodium chloride. When you irrigate a lot, remember that sodium is hand in glove with water. So sodium goes into the cell and out of the cell. And it doesn't matter, it has no boundaries. It's just going to be kind of like an amoeba. When you use tap water, it does not flow in and out of the cell. It stays out of the cell. Okay, so, but you're going to see at your facility, and I myself have done it, you go to the tap water and get it. If you are not irrigating it very frequently, every 4 hours is fine, right? We drink water every 4 hours, right? So what was that wiggling? Was that, it sounded like wheels.
I think it's coming from outside.
Just want to make sure. So then, okay, now this is important, so I'm kind of bummed out that this is all going out, because I'm trying to really, I want you to write, because this will be a state board question. What do you irrigate with? And it is sodium chloride. What really happens that you're going to see is going to be water. Why are you going to see them use water? Because if there's not a problem and they're only irrigating every 4 hours, it's no big deal. When you start irrigating frequently, it becomes a big deal, and you have to use sodium chloride at that point.
So how many hours do you say? Like every 2 hours?
Typically, it's in the order that is written, and typically it's every 4 hours. It could be every 2 hours.
So if it's every 2 hours, that's when you would for sure use.
Yeah, I would when I'm starting to get that way. Yes, I would. Yeah, Devlin.
When you say irrigate, what do you?
Irrigate the whole body.
This is what I mean when I say irrigating. Absolutely. Good morning. This is irrigating. This is down my nose, down my esophagus. This is this is irrigating. Okay? Now, if it irrigates that easy, oh, I love that. What a blessing.
Oh, yeah, it is.
I want to call Wayne right now. We prayed for rain this morning on the way to work. We, honest to God. What's that? You know, there's this lonely umbrella in 145, and it's all got gunk on it. I'm going to wipe that gunk off it, but I have one in my trunk too. Okay, so anyways, if you go to irrigate this, can I have your attention? And if it goes in and you put a little force behind it, it's not going to be that, that's fine. But if you go to irrigate this and you're having to, really work it, then it's more than likely clogged. So then you kind of have to play with it a little bit. Pull it back a little bit, push it forward a little bit, pull it back, push it in. And
You gotta speak louder, kid.
I hear you anymore.
We can hear you fine before the rain,
when Wayne worked for the water company, I always knew what the water level was up at Lake Hemet, because that's, that was his job, not only to measure it and know it, but it helped the water company not have to buy water from Metropolitan. And so I don't know that anymore since he's retired, except for when it rains. Okay, so anyways, after you kind of play with it, now this is where you will hear little tricks. I don't want you to pay attention to those tricks till after you graduate. Okay?
Yes.
Because you are not supposed to do them, and I don't want you to think that you can before state boards. Okay? You'll have the rest of your career, and that's fine. But for right now, we're just irrigating it. If it free flows, we're fine. If there's resistance and we can't get it in, then we're going to have to pull it and reinsert it. Okay? Okay. Any other thoughts or questions on this? Where are we right now?
We're at 8:15.
Where's my phone?
You just had it because you looked at it.
Okay, what I want to do is I want to go over. It's weird. Where's my phone?
You want me to call you?
Yeah, would you please? Although I have it, hopefully. It would be embarrassing if my boss calls me and my phone rings, wouldn't it? I just had it. What? Yeah.
You did. You looked at it for the time right before break.
Oh. It was sideways.
It did ring. She
Just a
doesn't have it
second
on
here.
silent.
Okay, now it's off. Okay. It is 8:17, so we have about 10 more minutes. I want to go over the equipment with you, okay? Okay, Ellie's got the pen. Sorry, that's cool. Okay, so I want to add to this pen light, right? Because we need to have a pen light to see which nerves. Incidentally, on your body, you should have a pen light, you should have appendage scissors, you should have a pair of Kelly clamps. Oh, bless your heart, thank you. So you need to add to this pen light. Okay, that was, while I was waiting for the pen, my mind went over here. On your body, you should have a pen to write with. And then if your facility is kind of antiquated, but it used to be days wrote in black, PMs wrote in green, and nights did charting in red. That's kind of antiquated. You need to have a pen, and I would have a backup pen. You need to have a pin light on you. You need to have appendage scissors. You need to have a pair of Kelly clamps on you. Buy a pair of those. And then you want to have not a lot of cash. A lot of cash is $20. But you want to have $5, $6 in dollar bills, maybe a 5, a couple ones, a 5, and a couple quarters on your possession at all times. You don't know what's going to happen. And the thing of it is, when you're in your facility, people are looking to you to solve the problem. Okay, remember I said I always liked being in a hospital because I always knew people smarter than me were in there. And when I would look around the room, and when I was the smartest one, I'd go, holy moly. Because the weight of accountability, we talked about that word, weighs on you. Okay, so let's go back to equipment. So we need a pen light to see. We need to have the NG tube. We're going to put it in KY jelly. We're going to have their chin to their chest and have them drink the water. We want a flex straw because when you're down like this, if you have something straight, it just doesn't work. We're going to have a Sharpie that we're going to mark on the NG tube how far to put it in after we checked it. And then we are going to take care of the nose. Okay, the tape. Let me go over what you are going to do on the tape, since we found the tape. Okay. Some people, you need to see if they have any allergies. This tape is, okay, I'm just going to pretend like this is a little bit longer. You're going to take a piece of tape like this. You are going to split it This part right here is gonna go on the nose, on the bridge of the nose. This is the part that one of them is gonna curl under the NG tube, and one of them is gonna go over the NG tube. And what you're trying to do is have it where it doesn't touch any of the skin, so it doesn't ulcerate it. Okay? And then you're gonna take another piece of tape this long, but you're not gonna chevron it, and it's gonna go over the nose to kind of hold everything in place. Okay? So back to the equipment now. You're gonna want to get, and this does come, typically this comes in this container with a little cloth, comes together. So you're going to want to get a, I don't know what you could call these, but a graduated, because what? You've got to measure, that 60 mLs that you're going to put in. So I'm going to call this a graduated container. You're going to want to have at least a 60, hopefully 100 ml Luer lock syringe. You're going to want to have the extension for the NG tube. You're going to want to have the pump for the tube feeding. You're going to want to have the tape again with the safety pin to kind of have a, what did you say, Lisa? A slack in the NG tube. And then you are, okay, so now you're good to go. So I want you to know, to the very end, I was in the clean utility room doing what I just did with you. Okay, now look, okay, yeah, I've got that, okay, then I put it in, I got the KY jelly, okay, then it's gonna be in, I have to tape it, yeah, I got my tape. That's another thing you wanna have on your possession, is tape. Okay, in your pocket, you wanna have tape. Okay, let's talk about that. Okay, I like that question. Thank you, Veronica. If you are going into a sterile cavity, you need to be aseptic without as much bacteria as you can. Okay? Is the stomach a sterile cavity? No, it is not. So you would just use normal gloves. Okay. Dealing with this tape and doing that chevron and everything with gloves, it's almost impossible unless you have a hand that perfectly fits gloves. If you have a little bit of slack in gloves, you're going to be, so, yes, you put them on, we get into this philosophical stance. To you, I should be saying, absolutely, wear gloves. Absolutely. You're facing your state boards. Wear gloves, wear gloves, wear gloves. But the reality of it is that you are an independent practitioner and you determine that. Okay? It doesn't hurt to have gloves in a pocket, and, I can honestly say that more times than not, I did that. But the question you ask yourself is, what cavity am I going to? Is it sterile? Okay, now, are the lungs sterile?
Yes.
You bet your bottom dollar. So when we do suctioning and we go into the lungs, yes, we wear sterile, we wear gloves. Okay. Really, the only sterile place in a hospital is the OR, and I even doubt that that is truly sterile. So we're kind of going for aseptic, without bacteria as much as possible. Okay, any other thoughts or questions on any of this? So now that I know where my phone is, it's 8:25. You guys are out of here at 8:30, right?
Yeah, she said she,
Oh, thank you. So what are we doing? How many stations do we have? We have 4. Okay, this is kind of good. We're getting out a few minutes early. If you need to talk to me, make sure that you do, so that we can kind of get a game plan and make sure everything is copacetic, okay? So go ahead and yell out on 1, 2, 3. Okay, you guys are set to leave. You're fine. You'd have to come, yeah. How about Monday after class? I'm gonna be taking 2 tests that day, which is a bummer, but that's kind of what we have to do.
Okay. I heard a lot of people it was a little hard.
You know what, people didn't do that bad. From what I'm hearing, they're overreacting. It was hard, but they are overreacting.
Sounds like a. I was trying to make a wave.
Yeah. Thank you. Okay, and then, we're going for no homework, and I'm like, I can't believe Karen didn't.
Oh, no, you did 6. You did the check mark
And I just forgot to put it on mine.
Yeah.
So your test score, you need to add 6 points to it, and I will do that.
Okay. Yeah, I don't have my workbook with me. I
I
always
believe
leave
you.
it at home.
I believe you. I totally
Okay,
believe you.
but I'll bring it to you.
No, that's fine.
Okay.
I'm totally-
I'll bring it
I'm
to you
totally
if
good with
anything.
that. And does this go in there? Okay.
There's only 4 stations.
Yeah.
How
Yes,
did
I
you do
did.
it? Count to 4?
Yes, I did. So I got taken, okay, now, I am so happy to see you.
Oh,
I am
I
so
thought you
happy.
had it. I was like, no.
No, I was like, oh, man, I thought because of this COVID stuff,
Oh,
oh, bless your heart.
but that was even worse because I got sick and I really thought I had come. Oh, no, I like this. I love my back. I got a car swap this and my car way over there. It's hot. So I was like,
I didn't bring the blue book. Do you need the blue book? It just makes it a little easier. You want me to get it? Ellie, a sheet of paper too for signing.
yeah.
I needed to talk to him. Something about Prosper. Yeah. I got a list of what they need. And who needs what and who needs what. If they for Castle Wet for Canyon Springs, they have to have their immunization for what or COVID, and I think there's only one we're talking about.
What if like they made it up, they created the lab there.
So I'm still working on getting it, but
Thank you for being ready for class.
Once you start with the clinic. Maria.
Is the final for Skills Lab week 6?
Huh?
Is the final for Skills Lab really week 6?
Is really what?
Is it really on week 6? Because it says,
It's whatever the schedule says.
okay. Or I think that's the wrong schedule.
Only Tuesday and Wednesday.
Oh, wait, I know this. Don't worry, I know we have to get those.
For every facility you go to, they want to know
Like right
before
here,
you
on the
step
schedule
foot
at the
in their
bottom.
doors that you do not have COVID. That's why I said it, I
I
don't know,
would
did I
check with
say
him.
it's
Okay.
Tuesday? I
Because
said it
I'm not
Tuesday.
exactly sure what she
Somebody
has it
asked me,
scheduled out.
I did say it, I said, remember some of you walked around with me the track and then afterwards we went to over where we get COVID tested.
Yeah, I
And
remember
did-
you said that.
I did say it, I said, you need to get COVID tested before we go to Canyon. And Tuesday,
Yes, sir, tomorrow, so
Wednesday.
you have to get COVID tested before you come to orientation tomorrow.
You're gonna get COVID tested today.
Yeah.
Because if you get one tomorrow, one, finding a site that early in the morning, because you have to drive all the way to Palm Springs, is gonna be very difficult. And two, you need them resulted before we show up. So please, please, please don't be like my student over the summer who showed up to clinical with her COVID test done a half hour before you start and there's no results.
Legend.
You will not be able to get in. Not legend, like pull my hair out. Sorry, you have to make up a day. And keep in mind, as far as
I do too, but they're not gonna take your test. Not for your initial. That's why I said.
Okay, I have a question. I did mine.
hold on, there's too much going on.
Yeah, those will work in some cases, so hang on to them.
Are you going to? All right, so class, those who are going to Canyon tomorrow, please listen up. Those who are not going to Canyon tomorrow, you still need to listen. Before going to Canyon, you need to have a negative COVID test. Not done at home, because how can you prove that? A picture on your phone is not proof to a facility. Now, there will be some instances where you can use at-home tests, but you take that test in person at the facility, okay? You will need a copy of your COVID card when you go to the facility. If you don't have your COVID test, all 3 vaccines done, you won't be able to go tomorrow. And we don't know how we're gonna make up that time for you guys. Because they only offer the class
Yeah, I'm still trying to find out.
every once in a while.
Yeah.
Now, if you have the Johnson & Johnson, they count fully vaccinated as 2. Because that first in this series was only 1 shot. So if you've had Moderna or Pfizer, that's gonna be 3 to be counted as fully vaccinated.
They may make an exception for your orientation, because you're not actually going in, and they do have some cases of COVID, but they're quarantined. They were supposed to be over, I'm sorry, they were supposed to be over on the 4th. Their quarantine was done on the 4th. But still, we don't know what they're requiring, other than you have to be vaccinated for orientation. And we need to show proof of a negative test. If they change, and they may, because lots of facilities do, they change when circumstances change. We have no control over that. No, none whatsoever. We just have to comply. I know it's a lot of changes on you guys, and I apologize for that.
Right.
So question number 1, which of the following approaches is best to take when the psych tech discovers that a post-operative client who practices Judaism is eating only fruit and bread on his fruit tray?
Do your best to accommodate.
So do our best to accommodate. Now, who would we ask to help us with that? Dietitian, or like the kitchen staff. We do want to tell them, okay, you had surgery, so we do need to increase protein so we can increase healing. So instead of doing things like meat, what about doing things like legumes or nuts? Or what about protein supplements that don't have meat in there? So there's many, even plant-based protein supplements that they can be taking, because we do want to increase their protein to help aid their healing. We may also ask the kitchen staff to make sure that foods are kept separate, that meat isn't touching fruit and stuff like that. Number 2, which diet is best for a client with the diagnosis of cardiovascular disease? Low sodium, and also low fats or low lipids. I'm sorry? So 1,500 calorie diets are usually used to control sugars. That would be a diabetic client. Low sodium, low fats. Now, when we talk about low fats, that also includes cholesterol, right? Yes. Cholesterols are a type of fats. So even though we think of eggs as not being very fatty, that egg yolk is very high in cholesterol. So those are potentially not best for heart-healthy diets. Number 3, which should be included when teaching about dietary restrictions for a client with hypertension? Hypertension means high blood pressure.
So it's gonna be like low sugars.
I hear low sodium, yes. Now this is where the number 1,500 comes into play. So we would want to restrict sodium to 1,500 milligrams of sodium. Sometimes they'll also restrict it up to 2 grams sodium. It depends on kind of how the client's condition is.
You said 2 to what?
I'm sorry?
What was the range, 2 to 15 milligrams?
1,500 milligrams or 2,000 milligrams. So 1.5 grams or 2 grams. That's how they convert. You guys will learn when Kim goes over math.
Thank you.
Now, the reason why we restrict sodium is because wherever sodium goes, fluids follow. So you have a person with high blood pressure already. Then they eat a bunch of salt. And then here comes fluid. That's extra fluid that's going to be going into our veins, into our circulatory system. So have you guys ever, like, we're in the room right here. What happens if we bring in more fluid or more students into this room? We're going to get crammed tighter into this small space. What is that going to do to the tension in here? It's going to increase our tension. So it would make us hypertensive. Get it? Ha ha. Punny. So wherever sodium goes, fluid follows. Which type of diets would be given to a client with a diagnosis of spastic quadriplegia, who has what we call dysphagia? So spastic quadriplegia is where the muscles are very tense. Quadriplegia is both legs and both arms paralyzed. Yikes. That was Superman. He was making the movies, got into an accident. I think he fell off a horse or something like that. Had a neck injury, and then was bound to a wheelchair because he couldn't move from the neck below. So a spastic quadriplegic patient who has dysphagia. Dysphagia means difficulty swallowing or eating. So what kind of diet would we give for that patient? Liquid? For the rest of their lives?
Only the drinks are
The drinks may be thickened. Depends if they have a hard time swallowing fluids. And what about the food? We're going to give them a solid steak? Cooked well done? No, that's a choking hazard. We're going to maybe chop with lots of sauces, or puree works. Now, speech therapy will come in, assess the client and how they're swallowing, and they listen with the stethoscope to listen for aspirations or fluid going into the airway. So as long as they're swallowing appropriately, no problem. But if they're swallowing appropriately, do they have dysphagia? No. So dysphagia, we would call in speech therapy. They would assess and give the doctor recommendations on what level of minced and moist or puree kind of diet. But we would have definitely put them on a specialized diet for swallowing and dysphagia. Yeah, so we would want either puree or chopped. Number 5, which foods should be omitted, left out, when doing meal planning with a client with a diagnosis of gastric ulcer? We want to omit or restrict anything with caffeine, anything that is spicy, anything that has flavor, right? They want to put those clients on a bland diet. Now this one should be similar. What are some interventions that should be implemented for a client who experiences gastroesophageal reflux disease, or called GERD, after meals? So us who are psych techs, we can teach them to avoid foods that cause them discomfort. So I have GERD real bad, and I avoid like the plague tomato-based red sauce. You will never, ever, ever catch me eating spaghetti. Ever. Spaghetti. Seldomly, because if I eat pizza, I pay the price. Pain and suffering. So yes, I eat pizza, not often, not more than once a month. It kills, hurts so bad. Awful. So avoid eating foods that trigger. Avoid laying down after eating. Why?
Because you can get heartburn. Or
Gravity is our friend. When we're sitting up, our food is staying down in our stomach. When we lay down, can the food spill out of the stomach?
Yes.
It can if our sphincter between the stomach and the right in the diaphragm, if that sphincter is weak, it'll spill out. So it's almost like having a water bottle that you didn't tighten the lid on all the way. It tips on the side and it spills out. So you want to teach them to stay either sitting or laying with their head elevated after eating. We want to tell them to cut down on smoking because smoking increases stomach acid. We want to teach them to eat frequent and smaller sized meals. And we want to teach them weight management techniques. Number 7, how can the psych tech assist when delivering the dinner tray to a client whose dominant arm is in a cast elevated on 2 pillows? So their dominant arm out of service basically, right? It's gonna be really hard to do that. Where are we gonna put the tray?
Next to the non-dominant arm?
We're gonna put it next to the non-dominant arm. If they have one hand that's functional, how are they gonna cut the steak?
They're not. Why is this?
So how can you help them?
Hand over hand.
We're gonna cut it in smaller pieces. Now I wish we could do hand over hand teaching, but this one's in a cast. Now we do want to try to keep them as functional as possible. So if they have one arm that's working, we definitely want them to do as much as they can, because then they're going to lose all function and then become dependent on you. I'm sorry, but I'm not taking care of my patient for the rest of my life. I'm take them home, bathe them. You know, they're like my little baby doll. I don't want to do that. I want my house to be my house and my work to be my work. So we do want to kind of maintain their functionality so that way they don't become dependent on us. No, so cutting the food into small pieces. What about like putting butter on the bread or stirring coffee and sugar together? So we want to try to assist them with things that would require 2 hands. Now, could they butter bread with one hand? Yeah, it's going to be a little hard. We want to encourage them, and if they really can't do it, then we can assist them. What about, we can probably tear open the sugar packets, but then they can pick up the sugar packets and pour it in there and stir it with one hand. They would just get really good dexterity in their non-dominant hand. So my grandma grew up in a time where left-handeds were sinister and evil. So when she grew up as a kid, as a left-handed kid, she had to learn to do a lot of stuff with the right hand. And then some things she did do right-handed. So, you know, is it impossible to learn how to do things with the non-dominant hand? No, it's not impossible. So you're actually just strengthening them for the long run. Okay. Which test is best for identifying correct placement of a newly inserted nasogastric tube? Everyone should scream this one. You guys know this. What is it? Loud and proud.
Gastric.
Chest x-ray. This is chest x-ray is gold standard for a brand new tube. Now, are we going to do a chest x-ray every time we go to access that tube or use that tube? No. We don't want to be, 1, x-rays are expensive. 2, we're exposing the patient to radiation. 3, it's very timely because not all facilities have an x-ray department right there. I don't think, can't Patton have an x-ray department? Yeah? Canyon does not. So if a patient needs an x-ray, they go out to the hospital, they have to come back. I could have given my meds a long time ago if I didn't have to wait for a chest x-ray, right? So we don't do a chest x-ray every single time. This is where we swoosh the auscultation and draw back for the aspiration. Number 9, which is the most important for the psych tech to take when feeding a client through a nasal gastric tube?
Make sure it's in stem.
Make sure it's in place, and we want to check for
Gas,
That they're sitting.
gastric juice, but there's an R word to it.
residual.
Residual. We're going to check for residual. So what that's looking for, think of like residue on your bathtub. What is it?
RESIDU.
So what is the residue on your bathtub? It's leftover soap. So what is residual in your stomach?
Leftovers in my stomach. Leftover food.
Leftover food in the stomach. Number 10. The psych tech is preparing to administer nutrition, also known as a gavage, through a nasogastric tube. In which position should the client be placed? Any Fowlers? So low Fowlers is okay?
High fat.
So medium to high Fowlers. Semi-Fowlers to high Fowlers. Now the big thing with the nasogastric tube is most of us have our intact sphincter between the esophagus and the stomach. When we have a tube down there, what is that doing to that sphincter? Holding it open. It can't close because there's a tube in the way. So when we lay them flat, we're at risk of the food going up into the esophagus or even them breathing it in. So we do them in the high Fowlers position. Number 11. What dangerous complication may occur if a nasogastric feeding is administered too quickly? We run the risk of aspiration. What does the word aspiration mean? There we go. I heard it back there. It's fluid in a place where it doesn't belong. So when we aspirate gastric content to check for residual, we're bringing the fluid that's supposed to be in the stomach and putting it into a syringe. Is that where it belongs? No. What about when we give injections? We give an injection and we're pulling for aspiration. What we're doing is we're checking to see if we're in a blood vessel, trying to pull the fluid, which is our blood, into the syringe. Do we want aspiration at that time? No, but it's bringing blood into the syringe where it doesn't belong. Aspiration when it goes into the lungs. Gastric content, when we aspirate gastric content into the lungs, that's fluid going where it doesn't belong. So that's what the word aspiration means. Number 18. What is the rationale for keeping a patient NPO before surgery 8 to 10 hours? What does NPO mean?
Nothing by mouth.
Nothing by mouth. But how do we get nothing by mouth from NPO?
Nothing per os.
Nil per os. Whew, those Latin words. Rough, huh? Nil per os. So os means mouth. Nil means nothing. We should all know per, right? Per is by. So nothing by mouth, same thing as nil per os. So why do we keep the patient's NPO before having surgery? So when we go into surgery, we put the patient under anesthesia. So anesthesia is almost a sleep like death. They're paralyzed, they're sleeping, and we are knocking out the body's autonomic and sympathetic nervous system. we're putting them dead sleep. So even our smooth muscle, which does all our involuntary actions like digesting, we don't think to digest, right? No. We don't think to breathe, right? No. Those are all our autonomic nervous system taking over. When we give patients anesthesia, we're knocking that out. Their brain doesn't communicate with the bladder. Their brain doesn't communicate with the stomach to digest. So what usually happens to the stomach is as it's going to sleep, it wants to empty. We have to get rid of this stuff. We can't process it, get rid of it. They tend to vomit. So that's why after anesthesia, patients come out very nauseous. When they're very nauseous, they tend to throw up. But if their stomach isn't communicating with their brain, what's their airway doing? That's not communicating either. So they're at very, very, very high risk of breathing in their vomit. So that's the reason we keep them NPO, because if they have nothing in their stomach, they have nothing to throw up. Okay, so question 125. A client is complaining of abdominal pain and starts to vomit.
125.
125. What action should be taken by the psych tech? So we can place them on the side, especially if they're unconscious, because then the vomit can leak out. If they are aware of what's going on, what can we do? A kidney basin or a bucket. Sometimes hospitals have those little vomit bags. Are we going to want to tell the patient to swallow their vomit? Sick. That's kind of gross. Plus, let's say, for example, they ingested a poison and their body's trying to get rid of it because it realizes it's poison. We're not going to want them to swallow it back down. That's just re-exposing them to the toxin. So the body is real good at realizing what is bad for it and what is good for it. So anybody eat real junky for a long period of time and then they go and eat a salad and you feel pretty good? It's not just emotional, it's not just psychological. The body knows and it will tell you by feeling better. Anybody go on a pretty strict diet and then they fall off their diet for one day and you say, oh, I feel so sick. I feel so sick. Why? The body is really good at telling you what's good for it if you listen to it and pay attention to the clues. So, there's a little phrase that says, let's see, food can either be the most potent medicine or the most toxic poison. Depends on which type of food you pick. Now, if a patient does throw up, are we going to just toss it? What are we going to do? We want to assess it.
Oh yeah, makes sense.
How would we know the reason for the patient throwing up if we don't look at it and assess it? She said, yeah, I'm going to throw it away back there. I see those ladies, just cover it up, cover it up. Now, what were to happen if your patient threw up, you tossed it, and then they're going through the med cart and they're doing their narcotic count, and they're like, oh my God, 10 pills of Norco are gone. Dude. they're gonna look at me like I stole them. But wait a minute, that patient threw up 10 pills. That patient took the meds, not me. How would you know if you didn't look at it? So we do want to inspect for contents, color, amount, characteristics. You want to pay attention with how much force the vomit comes out. What does projectile vomiting mean? That was someone's question the other day.
Exorcist.
Exorcist. Which video was it? So who has seen The Exorcist? Where the head spins in a circle. I can't do that, but I can mock it. The head spins in a circle, and what happens when the mouth opens?
That's disgusting.
Flies out at an uncontrolled rate. So it's almost like you projectiled that vomit. Drunk people do that. Typically, neurologically impaired people do that too. When they have a neurological hit, projectile vomiting. Now, why do drunk people throw up? Why do you throw up because of alcohol? Because it's poison. Your body knows it's poison. It wants to get rid of it. Right? Now, what happens if your patient throws up and it comes out bloody? What are we going to suspect? Could be cancer. Gastric bleeding and ulcers is probably your number one answer to that question. Blood in the stomach, gastric ulcers. Now, gastric ulcers can be caused from a couple different things. One would be high amounts of acid in the stomach. Another would be a bacteria called H. pylori. In order to treat that, you gotta test it, and then the patient would be put on antibiotics, and then their stomach acid problems or GERD would get better.
I'm sorry, what number was that?
125. Okay. So that was it for feeding questions. So you guys can be free with your day if you want. If you don't want, you can hang out in here, but I'm not staying. I got jokes today. Oh, thank you. Okay, thank you.
Oh, looks like I didn't have to give those since your speech. Cool. Speech worked.
Okay.
Devlin,
I'll show you.
I need to talk to you.
I spoke with parents. She's going to be in a nursing home.
Sorry, I'm trying to take a picture of this. You can go. Trust me, there's no one in there. Oh my bad, my bad.
Oh, the freaking college I have no service. I was like, is all about food?
You're a canyon, but you're not a canyon on Fridays. So you can make the nursing on Friday evening. So if you want to go,
Is it across the street? But I don't know if I need to take it. I need a backup. Okay, because I gotta do that when I see that.
How many classes?
400 a year.
You
have your airdrop on?
Oh.
Yeah. No, because it would be a full day.